Good afternoon, everybody. Welcome to this ESSKA webinar, together with our continuous professional education partner, Episurf Medical. A warm welcome to the ESSKA community, to our faculty, and everybody joining us today for this webinar. Today, we will cover an exciting topic, focal resurfacing implants for knee and ankle. We have an outstanding faculty, and for sure we will have fun and learn a lot from this session. For those joining for the first time, what is ESSKA? ESSKA is all about education, knowledge, arthroscopy, science, research, and much more. Be part of our scientific program in the upcoming ESSKA Congress in April. Remember that the abstract submission has been extended, so you still have a chance to participate, and you can follow us online and always on the social media to be aware of all the novelties. Thank you so much to our partner Episurf Medical for making this webinar possible. And some practical issues. ESSKA and members, Academy users, please claim your attendance certificate from your ESSKA Academy. Please use the Q&A to submit your questions to speakers, and please use the chat only for general comments. My name is Hélder Pereira. I come from Portugal. I am a dedicated knee and ankle surgeon. I also work in Spain in the República de Prado FIFA Medical Center. And I will be moderating this session with this program, which will start with the focal knee implant, background and indications, surgical technique and clinical experience, case followed by some case presentations. On the second part, we will have this same implant, but dedicated to the ankle joint. Also, the background and indications, clinical outcomes, and experience, followed by some case presentations, hopefully with a joyful discussion in the end. Here we have our outstanding faculty. Professor Martin Lind from Denmark will talk about the background and indications for focal knee implants, followed by Mr. Tim Spalding from the UK, who will share the surgical technique and the clinical outcomes from the knee. And we will keep on with the ankle joint, where myself will present the background and indications, and my great friend and tutor, Mr. Niek van Dijk, Professor Niek van Dijk, will share the clinical outcome and experience. It's nice that we have people joining from all over, from Jordan, from the US. Greetings, everybody. And thank you for participating, and let's all have fun. Don't forget to use the Q&A when the Poland. So we are gathering a little bit the word Belgium. Nice. This new technology approach for sure came to stay because it makes our distances shorter.
So I'll start off with my presentation, and I'll go through the background and indication for focal knee surfacing implant uses in the knees. And this is my disclosures. And first, we'll have a polling question. And that's just to see how many have actually tried using resurfacing implant in the knee or in the ankle. Just to get an overview of who has experience with these still not that used surgical techniques. Thank you. So about 25% of the participants. So what is the clinical problem? Full thickness cartilage lesions due to early degenerative changes in middle-aged patients that still have not progressed to fulminant osteoarthritis. These patients can have as symptomatic and disabling symptoms as fulminant osteoarthritis. And we also know that cartilage repair procedures such as bone marrow stimulation or cell transplantation, these have less successful outcomes in these middle-aged patients. So we have a problem with severely symptomatic cartilage pathology and the lack of options to treat biologically these lesions. These patients that are not fulminant osteoarthritis, they are not candidates for normal arthroplasty treatment. So we do have this gap between disabling early osteoarthritic lesions that cannot be treated with biology and not be treated with arthroplasty. So that's a gap we have for patients. And here we see the study I just mentioned from Norway, which demonstrated that these patients with focal cartilage lesions, can have severely symptoms from these focal cartilage lesions that are as bad as fulminant osteoarthritis. So this is an overview of the treatment gap. We have biology of cartilage repair, and then we have arthroplasty. And in this treatment gap, we have patients that have a demand for an active lifestyle. They want also short rehabilitation times and predictable clinical outcome for the treatment they get. So the surgical principle for resurfacing implants is to replace pathologic cartilage and related to subchondral bone with a metallic implant that restores the joint congruity. In the early times of these implants, they got many different names, such as focal anatomic resurfacing implants, condylar resurfacing implants, partial resurfacing implants, inlay resurfacing implants, and focal prosthetic resurfacing. But they are all the same. So the existing implants today, the first one on the market was the hemicap implant that was introduced 18 years ago. And there exists implants for condylar and trochlear resurfacing and also unicompartmental replacements. More recently, we have the biopoly implants, which uses a different material principle with a polymer surface on a metal backing and pin setup for implanting. And then there's the Episila implants from Episurf, Sweden, which we are having our webinar about today. The Episila was introduced in 2013, and there exists implants for both condylar and trochlear resurfacing. So the first clinical experience with these implants were pretty scarce with small patient series. The biggest studies that came out about 5 years ago based on the hemicap implant and from a Danish center with 74 patients in the knee, and they found pretty good improvement in patient-reported outcomes using the KSS score, and also good improvement in pain reduction using VAS pain scores. And these outcomes were predictable 2 years out. But in the study also, there was a rather high percentage of implants needed to be revised to arthroplasty. A few registers of knee arthroplasty has also included these resurfacing implants, and here are some results from the Danish knee register. And they showed that these implants can have a pretty high revision rate. In 230 implantation, there was a 45% revision rate after 6 years, which was concluded to be rather disastrous compared to the normal arthroplasty treatments. So looking at an implant like the Episila, which we see here, which consists of a cobalt chrome surface, then it's also having a titanium and hydroxyapatite coating that can attract bone. And the solutions that are then being solved by this are the following. So some of the challenges that we have with mini-metal implants is that the surrounding cartilage must accept and preferably seal to the implants. And this is what has been tried with the Episila material choice. Also, an implant like the Episila must be able to bond strongly to the bone. And this has also been solved by material technique. And also the implants should not damage the opposing cartilage. So all these challenges have been tried to be solved by the Episila implant. So the surface is made by very highly polished, ultra smooth cobalt chrome. And the surface is specially patient designed to have the same anatomical surface as the condyle of the implant. So it's completely anatomical, and that creates an optimal congruity, which then should not damage the opposing cartilage. Then there's both titanium and hydroxyapatite coating, which not only will seal the implant to the cartilage at the top, but also ensure strong bone healing and apposition. And this has been demonstrated in animal studies, that this hydroxyapatite coating actually is able to seal and attract cartilage healing at the surface. Also, the hydroxyapatite coating has been shown to rapid fix the Episila implant to the bone. And since the congruity of the surface fits the patient's own anatomy, and also that implantation is done with a 0.5 to 1 millimeter countersinking, that has been shown that the implant and the technique does not damage the opposing cartilage. So the indication for using the Episila implant is in patients with a focal chondral or osteochondral lesion of the femoral knee condyles or trochlea. And of course, the patient should have significant pain and disability. And preferably, the patient should also have a history of failed non-operative treatment, so that the lesion would require some kind of surgical treatment. The contraindications are the following. It should not be non-focal defects. The patient should not have inflammatory arthritis or fulminant radiographic osteoarthritis. And there should also not be inadequate bone stock, so that the Episila cannot be fully supported by bone. And also, if there's severe cartilage lesion to the opposing tibial cartilage, that would be a contraindication. So the different implants that exist is seen here. So there's a so-called Episila solar, the trochlea solar, that is used in the trochlea. Then there's two femoral condyle implants, the femoral twin implant, which is used for larger defects, and the solar implant that is circular, that can be used for smaller lesions. And the different sizes that exist is the femoral solo implants goes from 12 to 20 millimeters in diameter. The trochlea implants goes from 20 to 29 millimeters in diameter. And then the twin implants can go from 15 to 25 millimeters which in the double contour will range from 23 to 35 millimeters in sagittal lengths. The concept for manufacturing the implant is that an special MRI scanning with special sequences is made to identify not only the cartilage pathology, but also the three-dimensional anatomy of the patient. And that is sent to the company to manufacture the implants, and then a report is given to the surgeon. And from that report, the lesion is characterized. The technique is guided with the positioning of the guides that is used for reaming to the implants, and also the final positioning of the implants can be seen in that report. So take-home messages from background and indication is that there exists this treatment gap for patients with significant symptomatic localized cartilage lesion in middle-aged patients that are still not osteoarthritis, where mini-resurfacing implant can be a treatment option that is both feasible and have clinical beneficial outcome. And the Episila implant represents a second-generation mini-resurfacing implant that is anatomically patient-specific and has advanced healing features. Thank you very much. And that will lead me to give the word to Tim Spalding, which will continue this knee presentation and cover the surgical technique and also the known clinical outcomes with the Episila implant.
Thank you for that excellent overview of the understanding of what this Episila is really all about. And what I'd like to cover is just go a little more detail on that process, the physical process of doing it, then the surgical technique. focus on some clinical outcomes and then reiterate it again at the end the indications for this. So my disclosures are here, and I'm on the medical advisory board for Episurf. So the process, again, then when we find a patient who may be suitable, we send the MRI scan to Episurf, the company, with specific 3D sequences. And the MRI scanner has to be tuned and tested that the sequences are appropriate to be able to generate that 3D mapping. And then in return, we get back this damage marking report and a proposed design for the implant and the guides and how they would sit. So if we like it, then we accept that, or we can modify and say want a bit more covered or less covered. And then finally, after 4 to 6 weeks, we get the implant itself, the guide and the instruments. And you can see on the right-hand side here the limited instruments that are required for the implantation with the drill and the guide and then the impactor. So this is an example, and online we can tune in and then see, as you see on the bottom right here, this is a 3D model that we can spin around. We can apply the implant to it, put the guide on top, and then turn it around to see exactly where it's sitting. So this gives us the ability to visualize in 3D beforehand what's going to happen and where it'll actually sit. And then the images that we send through initially are here, so by screening through, we can identify and understand the subchondral element to the damaged area, and in that way agree the exact plan. So finally then we can print out and look at the PDF report, which goes through in various detail, analyzing exactly and showing us where the implant was designed to sit, what it looks like, what it's based on, and assessing the depth for the subchondral areas, so we can fine-tune this and see exactly what we need, and that comes as this damage marking report, before eventually we sign off the implant with that final design. And then we can see from that the guide that's going to be produced, this 3D printed guide, and where it's going to sit. And then it comes on top of that, the larger page, which then at the time of surgery is useful to print out and actually see, because in that way we can identify where the guide's going to sit in relation to the anatomical landmarks. And then finally do the operation, and that's the afterwards. So for the actual operation, then the design image is produced, and we can print that with the implant. We check the kit that's arrived, then it's the arthrotomy, implant, and the rehabilitation. So here is an operation then on the medial side. Left knee, medial femoral condyle. We're doing a subvastus approach, which allows the space to put on the guide, marking out the area and just examining exactly what it looks like compared to the guide that we've received and to the damage marking report. And then this 3D printed guide really it's very impressive how it just sits in one place. It easily goes on there, can't really move around, and it's just rigidly held there as it fits exactly on the contour. Held on with 3 pins. The 2 on this side are parallel, therefore if we want to slide the guide out, we can easily put it back on again after removing the 3rd pin. So in that way, if we want to get the depth exactly right, we can get a better view. So then just again palpating the area before applying the guides. So the first guide is set then to drill just with the starting drill, and then we move on to doing the exact depth part of it. So once that bit is taken out, then we can insert that epi guide itself, which then we want to tune into the exact depth. Now we set this at 0 because it's designed to be at 0 at the time you put it in, and that should take us to exactly the right depth. So then using the drill, that's cleared the space, and you can see down there exactly what it then looks like. So we take that out, and that should be set exactly right. So then with the guide, we've got to put that in, and we want to see that is sitting this 0.5 millimeter below the joint surface. So we use one of the pins just to probe with. And if you want to, you can then take off the guide itself to see exactly what the depth is. Now, if it's not deep enough, then we turn the dial, and every marking of 2 is at 0.2 millimeters depth. And then sequentially, you can go down deeper till it sits exactly, it's just below the joint surface. It's 0.5 millimeter. You can use the arthroscope to look in there and see exactly the depth if you want a better view. So it's important then to mark the top so we know the orientation, because the implant comes with a small mark on it so that we know which way around it should be to the patient. Once the guide is out the way, then it's easier to see exactly how the epidummy is sitting. And then once we're happy with that depth, then applying the implant and inserting it. At that point, you can see the HA coating on the side, and then either using the standard epimandrel, as it's called, or the custom printed one that's shaped for it, then it can be gently impacted into place. So essentially, that is the principle of the operation and the detail to make sure that it sits in exactly the right place. Key points then, the guide position is very accurate. It puts exactly where it wants to go, covering the defect as the map. And then we're aiming for this point 0.5 millimeter or so below the surface. Proud is bad, is what we're trying to say. For the twin implant, as you heard, this is then covering a larger area. You can see the final design on the left-hand side, and then it's a bigger guide. You turn the insert round and then drill for the top half to make this sort of figure of 8 socket. And again, you can drill down to exactly the right depth to make sure it's going to sit there. And by looking in, you have to wash out the debris to be able to see. And then when it's in, take that guide off and once again get the exact right depth that we need, clear the edges of it, and then implant the actual Episila itself to the right depth. So that's the technique. The rehabilitation for the femoral articular surface, yes, 2 weeks touch weight bearing, then progress to full weight. Full range of movement is allowed, and strengthening work probably builds up from 8 weeks as symptoms allow. Now, if it's trochlear, then full weight bearing could be allowed because the patella is not taking the weight on it, and I tend to use a brace holding the leg straight for the first few weeks just to let it settle in. So moving on to the results, publications, the several preclinical and clinical publications, and the one I want to focus on is our recently published multi-center study of 80 patients, a consecutive series, and you can see all the surgeons on the right-hand side here who are involved in this. A prospective study, then in patients where no biological repair was indicated, and there were single lesions on the femoral condyle with good articular surface intact on the tibia. So we've collected the surgical data and then the outcome scores. So of those 80, then 2 have been revised, 1 declined to be followed up, and 2 have incomplete data, so have been excluded, and we're left with a 75 for in-depth analysis. You can see that 59% are female, see the age at 48, mean age, and BMI 28. 65% have had previous treatment from microfracture, mosaic-plasty, ACI, and simple debridement. The breakdown on the right-hand side, the trochlear with the solo or the twin, and then 65 on the condyles, 25 twin and 40 solo implants on the femoral condyle. So for the results of the whole and the whole group, this is on the left-hand side, the Coues domains over time with 24 months on the right-hand side of each of the groups for pain, symptoms, ADL, sport, and quality of life. So you can see the improvement over time that's maintained, and it's also reflected here on the right-hand side with the VAS scores, still looking good at the 24-month time point. This is not significant, and we haven't got enough patients in there to be able to answer the question as to whether the solo is better, the twin is better, or trochlear. But there's a hint of a tendency that maybe the trochlear seems to do well, which is impressive if we can help solve trochlear problems. And then on the right-hand side, the visual analog score stratified by the same bit, also reflecting maybe trochlear looking good. But there's a range here, and we need to identify these factors in the future, which patient will do well. Answering the question whether there is a benefit from doing this for previous treatment or not, the blue is being a primary case, and the red is prior cartilage procedure. So maybe primaries are doing better, but we need more data on this, which we'll get over time and as the numbers increase. I mentioned 2 revisions. First one was here, atypical lesion, a lot of bone marrow initially, and never really improved, and still getting pain at 15 months and was eventually revised to a uni knee. And the second one had previous oats, again, never really pain-free, some significant cysts around the implants, and we could ask for a thicker implant, thicker metal, to cater for that, but didn't really improve. And we actually took that out. This is my case, so I know the result. The patient is still happy. after bone grafting and treating with a chondroguide membrane to repair that area. So 1 infected, which is outside of this study period, has been revised, and then 2 have had arthroscopy for treating symptoms. So from that little study, the conclusions were that in this select cohort analysis, fine, we can see a low failure rate, which is very good at this time point, and very good clinical improvement. That design and the implantation is accurate and easy to achieve. And that report that I highlighted at the beginning really is accurate in helping us decide and also mapping out the area. Eventually, we've got to work on these optimal indications. This is another group. This is a cohort of 10 patients. The first lot performed in Sweden and showing the results published for the 24 months and then now just recently published at the 5 years, with no revisions in that group. And the red line in both is actually the Coos score at the 24 months. And you can see on the right-hand side, the grey line, it's still good at the longer time point. So this is nice to see that the improvement seems to be maintained over time. So that's what we hope for, and it's good to see these long-term studies, or this is a mid-term, really. So I'll finish with the indications, really, that we can say at this time for focal lesions. We mentioned that. Pain's got to be compatible. We do need good joint surfaces on the other side. That's essential. So when on the PA30 weight-bearing X-ray, there should be no loss of joint space. We need at least 50% or more of the meniscus without failure of that meniscus, neutral alignment, and obviously the good patient who's going to understand and not necessarily expect to go back to impact activities. And non-smokers, normal ligaments. And I think that really summarizes our main indications for this group. I do acknowledge the help from all the other authors in this study, and thank you, Martin, for your excellent presentation. And with that, I would hand back to Hélder again, but thank you.
Thank you, Tim, for such a comprehensive and great presentation. We go now for backgrounds and indications in the ankle joint, which is a completely different joint in terms of congruency, and this congruency makes different biomechanics. I have no disclosures, and I start with my pose. A 55-year-old military, sports activity is jogging, used to be jogging, pain on repetitive ankle swelling, progressively worse, impaired for long walks and profession, failed conservative treatment for 12 months, including injections and physiotherapy. MRI, bone edema, large OCD, overlying cartilage defects, 20 times 18 millimeters, cystic lesion, 25 times 32 in larger dimensions. These are the treatment options, and I would like to know, what would you guys consider as a first option? Keep on conservative and diminish activity, bone marrow stimulation technique, autologous osteochondral transplantation, membrane with bone graft, focal defect replacement, total ankle, or a fusion. And we will come back to this in the end of the presentation. So we already have the answer here, so we can see that 22% would consider focal metallic replacement, which is similar to those who would use a membrane with bone graft. Most would use osteochondral transplantation, and some 12% would use conservative treatment, which I find interesting, and bone marrow stimulation technique, only 2%, which I also find somewhat interesting. The goals for this 12 minutes are primary and secondary ankle OCDs. Where do we stand in the treatment in 2021? Is there a role for patient-specific metallic implant? Can we expect in future to have a patient-specific 3D printing biologic tissue engineer implant? Let's see. A Taylor OCD is a combined injury of the subchondral bone and its overlying cartilage and often has a severe impact on the quality of life of active patients. The pain comes from the bone, and also we see that we don't have global osteoarthritis. It's a global focal defect. Etiology of these injuries is broad with several possibilities. This is one case which happened to us in the lab after the instability event, which might cause it. And we consider primary as those not previously submitted to surgery, and secondary tells OCD all of those who have been submitted to failed primary surgery. Several staging methods of these injuries have been proposed, as well as treatment algorithms, which are helpful, but are far from having a full consensus. We have been working for several years in several possibilities for treatment, from the most simple and less invasive of treating the underlying bone with bone marrow stimulation, up to more advanced tissue engineering approaches. Our goal is always to preserve as much as possible the biology, the tissue, the bone, the cartilage, but this is when it is possible. This is a classic work from Niek's group, from the AMC group, and we see that amongst the most frequent treatments used in the ankle joint, which are a little bit different from those achieved in the knee based on the different biomechanics, are somewhat similar. And more recently, it has also been stated that today there is no superior treatment for primary OCD defects on the talus, and also there is no superior treatment for secondary OCD defects of the talus. So as Martin just said concerning the knee, also in the ankle, there is some gap to fill. So this patient-specific implants, and particularly Episurf, is intending for those people having a focal ankle talar dome OCD, causing pain and impairment, and to whom surgical treatment has been proposed. Usually these patients have a history of long failed conservative treatment. In my opinion, this is more dedicated to large OCD with loss of overlying cartilage, large bone defects, loss of peripheral support, what we often call the shoulder lesions, most of all in secondary lesions, and age might be an issue also, as previously stated. Once treating a young patient of 20 is probably different of treating a young patient of 55. The characteristics of the implant have been already described, and what I emphasize, besides the choice of the biomaterial, of the metal improved with hydroxyapatite, is the fact of the anatomy, the aim for anatomical surface replacement and patient specific. So the study starts with an imaging study from the patient, which is sent to the company. And we just saw with a similar study in MRI. Here, the CT is used to better quantify the volume of the bony defects. Contraindications. Broad osteoarthritis, it's not for sure an indication. Infection is also always a non-indication for replacement, any replacement. Inflammatory disease, inadequate bone stock, and severe injury on the opposing tibial side. These challenges have also been mentioned, but I will remember because I really think they are important, because either in the osteochondral transplantation and in the previous implants, we see that it is very important that the sealing of the implant and the surrounding cartilage approach, or even becoming an overlying cartilage coverage with that half millimeter. We have seen it happen, and it's desirable. We need it to be biocompatible, and it must bond to bone, because bone is key to success, as Niek uses to say, when we aim to treat such injuries. And we must not have a conflict with the opposing cartilage. And this is where also patient-specific implants present an advantage. Niek's group started this study a long time with very promising results, some of them with some problems of overlying implants. And this second generation implants aim to improve the anatomical replacement as well as to improve the connection to the biological tissue. So why patient specific? Perfect match with anatomy, increased feeling of the defect, diminished stress on the opposite side, diminished load on the implant interface, overcome uncontained injuries, and improve this 3D technology, also preparing the future. And the result is, this is the result we aim, and it's a courtesy of Episurf to me. Concerning future, tissue engineering enrolls a combination of all three key to success topics of tissue development, which are cells, scaffolds, and proteins, making them mature, fine-tune the behavior of cells, and this implants or scaffolds quite intelligent with different behaviors and in different levels, and all this can be achieved trying to match the host specificities, building and printing a scaffold embedded with different cells in different layers with different proteins. The interest on the scaffolds market has been growing with a lot of options in future. The search for more active and intelligent cells also, and the possibility of 3D printing with different layers is also developing. We have tried and worked a lot on this in the meniscus replacement, going only for animal studies. This is a 3D bioplotter, so it is possible to make printing of a scaffold, and hopefully in future we replicate this approach of the Episealer to have an effective biological implant. But in the meanwhile, we need to keep on developing this sequence and this approach so that fusion will be and total arthroplasty will be end resources in these cases. As take-home message, there is no evidence on best treatment for primary nor secondary focal talus OCD injuries. We still have challenges requiring a more effective approach in the treatment of these injuries. Patient-specific metallic implants today seem a promising option, particularly in a congruent joint like the talus. Maybe something for discussion is that the incongruency of the knee might make it a little bit more challenging. I don't know, but it's something to discuss. Further evidence is required, and I think that for the time being, controlled trials in dedicated study centers is the right way to develop and improve this technology. And I strongly believe that this is opening the door for future tissue engineering, biological, patient-specific reconstruction. In the meanwhile, remember, doctors can always make bad things worse. And be ready to expect the unexpected, because patients sometimes do some things unbelievable. So thank you so much for your attention. And I will now give the floor to my good friend and tutor, Niek van Dijk, who will explain us everything about the clinical outcome and experience of this focal patient-specific implants in the ankle. Niek, the floor is yours.
Thank you so much, Hélder, and thank you for your kind introduction and your excellent lecture. I would like to start with 2 poll questions. So, which 2 factors out of the 8 mentioned below are the most important to determine the treatment strategy for a Taylor OCD? Age of the patient and location of the lesion, the fact that the OCD is a primary or secondary lesion, the Burton-Hardy classification, the size of the lesion, depth of the lesion, shoulder lesion versus non-shoulder lesion, bone marrow edema on MRI, or CT scan classification. Interesting, good. I make a small picture of it. Okay, we can come back to it at the end. And the second poll question: what is the most important for the preoperative planning of microfracture of an OCD? The range of motion of the ankle, ligament laxity, CT scan, or all of the above? Yes, all of the above is correct. And then we will start with the lecture, and I pre-recorded the lecture, so Joseph, can you start my lecture, please?
Thank you, Hélder, for your kind introduction to this ESSKA webinar. The topic of my talk is treatment of Taylor OCD, what if biological options failed? And my disclosure is that I'm the editor-in-chief of the Journal of ESSKA, the GSOCOS, and I'm consultant for Episurf. So this is what we are talking about, the localized osteochondral defect of the talus. And the purpose of our treatment is twofold. It is to resolve the patient's symptoms and to prevent osteoarthritis. However, we know that the natural history is benign for lesions up till 12 millimeter. These do not go to osteoarthritis if left untreated. So the main reason to treat is to resolve the patient's symptoms. And the main symptom is pain, deep ankle pain on walking. The cause of the pain is mainly in the bone. The nerve endings in the subchondral bone detect the water pressure, which is the result of fissuring of defect in the subchondral bone. The content of the cartilage, which is mainly water, 75% of the cartilage is water, is compressed into the subchondral bone. And we see it on the T2 image on the MRI, persisting bone marrow edema. And this is the cause of the bone marrow edema. On the long term, if the pressure is high enough, it will lead to cystic lesions. We see those cystic lesions in congruent joints, like the ankle joint. We don't see it in incongruent joint, like the knee joint. Hélder has gone through the various treatments that exist for osteochondral defect. And it's interesting to see that the 4 treatment strategies, which not only treat the cartilage, but also the bone, have the highest percentage with excellent results, the ones in orange. Retrograde drilling is for large cystic lesions, and fixations is for lesions more than 50 millimeters. So the size of the lesion matters. And I want to introduce to you the concept of edge loading. And these 2 CT scans are from a patient that I treated some time ago. It was part of a study in which we had pre-operative CT scan, direct post-operative CT scan, and then at 1 year we made a CT scan. Pre-operative, we had a normal size lesion, but post-operative, now we have a large size lesion. Apparently I took more bone away than needed, or probably the cartilage was loose, and for whatever reason, now we have a critical size lesion. So this will fill with fibrocartilage, but the pressure will be on the edge of the defect, on the healthy hyaline cartilage of the edge of the defect. And indeed, at 1 year post-operative already, we see a new cyst, not under the former defect, which, as you see, is partly filled with bone, and the rest will be filled with fibrocartilage. But the pressure on the healthy edge of the defect has resulted in a new cystic lesion. So schematically, if we have, let's say 1 centimeter defect, debridement bone marrow stimulation will result in opening the subchondral bone with microfracturing, and then the defect will fill with fibrocartilage from the stem cells from the bone marrow. The subchondral bone plate will restore, and this will be the end result and a happy patient in the vast majority of cases. However, if we have a large size defect, a 50 millimeter defect, initially we will see the same. The defect will fill with fibrocartilage, but then there will be pressure on the edge of the defect, and the larger the defect, the higher the pressure on the edge, which might result in a cystic lesion, which we saw in patients that I showed you before. If this continues, then we might see additional cysts. We might see a cyst on the opposite side in the tibial plafond. Sometimes we see it in the medial malleolus and sometimes in the lateral malleolus. And this can then be the end result of such a situation. How can we prevent? We can prevent it by providing the patient with a filling of the defect that is capable of offloading the healthy cartilage. For example, a metal implant. If the metal implant is placed correctly, then on walking, the defect takes part of the load, connecting with the tibial plafond, and will offload and protect the edges of the defect. So what determines which treatment strategy is good for a certain patient? What determines our treatment strategy is mainly the size of the lesion, whether it's a primary or secondary surgery, and the age of the patient. Younger patient, adolescents, we will treat conservative longer than we will with adult patients. So the size of the lesion. If you see the treatment algorithm, then you see that the size indeed is important. Size up till 50 millimeter, excision curetized bone marrow stimulation, and the larger side lesion, then we go for different treatment strategies. Primary versus secondary lesions. For secondary lesions, we have other options, more invasive options when compared to the primary lesions. When do we treat? When the patient is symptomatic. We don't treat asymptomatic lesions. In general, deep ankle pain on walking. MRI can be important because it is a biological investigation. So if we see bone marrow edema correlates with pain. So absence of bone marrow edema is a strong indicator that this osteochondral defect is non or low symptomatic. Bone marrow edema, again, correlates with the pain. CT scan is important for pre-operative planning. It shows us exactly the size of the lesion, it shows us exactly the location of the lesion, and it shows what we have to treat, because the pain comes from the bone, so we need to be informed on the bone more than the cartilage. How do we treat? Well, with debridement bone marrow stimulation, which is still the gold standard. You can either go with distraction or you can go in plantar flexion. In general, I prefer the hyperplantar flexion for my approach. But with the soft tissue distractor, as you see here on the left, you can choose during your surgery. Sometimes it's better with some distraction, sometimes it's better with hyperplantar flexion, and sometimes you need a combination. It varies from patient to patient. And laxity is important, and the range of motion, preoperative range of motion, is important. If the range of motion is restricted, then hyperplantar flexion might be difficult. Sometimes we need an osteotomy. We need an osteotomy for an oat, we need an osteotomy for a metal implant, and for posterior lesions if you don't master hindfoot endoscopy approach. If you're uncertain if you can read the lesion, hyperplantar flexity can be helpful because it will show you exactly what you can expect during your surgery when you bring the ankle in hyperplantar flexion. Then to the metal implant. The first generation metal implant, we published our results, long-term, mid to long-term results of the first 52 patients, and we had a 94% survival rate. And the majority, 80%, indicated they would undergo the surgery again. And remember, these were all secondary lesions. They all had failed primary surgery, and many had 2 or 3 surgeries before. So why change a winning horse? Well, we had some problems with this first generation AB cap. And that was that the osteotomy was not precise. Sometimes some surgeons prefer to have a fluoroscopy to have it in the right location, but it is important to have the osteotomy at the exact location, so it needed skills to do it. The size of the implant, there is 12 sizes available, so there's never a size that is exactly fitting to the patient. It is always, the patient is always in between sizes. And it was difficult to measure and determine the size interoperatively because you needed this K-wire, and the K-wire had to be placed perpendicular in all directions. And if the cartilage is, and the surface is incongruent, which is the case because there is this osteochondral defect, then it was very difficult to determine the exact location of this K-wire. And if you were a few degrees off, then the cap was already tilted. The size of the screw, this was quite bulky, and there was no implant available for the lateral talar dome. So with the second generation, the Episila, now there is an osteotomy guide which gives us a precise osteotomy. The size of the implant, it's tailor-made to the patient, so it will always fit. And the guide is also tailor-made for the patient, so there is no room for mistake. The pre-operative planning. Pre-operative planning goes with MRI or CT scan, and you've seen this before. You get an exact three-dimensional view of the defect, and then the instruments are based on this 3D model, and the location and the size of the implant is based on this 3D model of the patient. As to the implantation, here you see the osteotomy guide. So a very precise osteotomy can be done up till 1 millimeter of the cartilage, and then you finish it off. It's an osteotome. Then you place the AP guide. There's only one position that it fits, and then you can have nice depth, and you can fine-tune the depth to your likings, and you then place the Episealer. We use the Hintermann spreader to get this nice opening of the ankle joint. We're currently performing a prospective multi-center study, a feasibility study, on the first 25 patients. So to conclude, the pain comes from the bone, treat the bone, remember the concept of edge loading, and what we didn't address in this talk was always check alignment. Orthopedics is alignment, and alignment is important. Then, before we go to this discussion, I like to present a case. It is the first case that received an Episealer. It's a case from Johannes Holz, who was so kind to provide me with the case. Johannes Holz is situated in Hamburg, as you probably know. 33-year-old male patient who had an ankle sprain in 2014. He was very sporty and was treated with an OATS in October 2014. He presented with persisting pain, deep ankle pain on walking, with a limited range of motion and a relatively normal X-ray. But on the MRI, you see the bone marrow edema, you see the cystic lesions in this patient. So it was decided to treat this patient with an Episealer. And here you see the pre-operative planning. Here you see the cystic lesions, a large cystic lesion in front, but also one here at the back. These still the two holes from the screws from the former osteotomy. And here you see the on the 3D model of this patient in pink, the damaged cartilage. There was an MRI and a CT scan, so this was the area of the damaged cartilage. Here also in pink, this is the oats, the plug, and this is the additional cyst here in the front. For the planning, here you see the Episealer, the planned Episealer and the planned Epi-Guide to accommodate, to place the Episealer in the exact anatomic location. And here, before this first surgery was carried out, there was a cadaver done with the same implant, same dummy implant. And here you see the nice opening that you get after an osteotomy. It's not just an osteotomy, but you also can tilt the talus, and that's why there is a lot of space to place the Epi-Guide. And here you see the Hintermann spreader to accommodate this position. So when you receive the pre-operative planning, it looks like this. Here you see the Epi-Guide. And of course, the tibia is in the way, but what it doesn't show is that you will tilt the talus during the surgery, and that's why you can place this Epi-Guide in order to drill and place your Episealer. The post-operative X-ray, and this is during arthroscopy during removal of the screws. And what is interesting, and you see it in all those patients, that if the defects, if the Episealer is placed below the surface, there is a cartilage, fibrocartilage cushion covering the defect. You see, covering the Episealer. And this acts as a spacer and helps to offload the edges of the defect. So it's better to place it relatively under recessed, and then you will get this cushion, which will help you to protect the opposite surface. This patient, this case, is recently published in Foot and Ankle Surgery. This is the 5-year post-operative X-ray, no degenerative changes. This is the FAST score, pre-operative, 3 months, 6 months already, almost 0, which continues to the 5-year follow-up. The foot and ankle outcome score at 1 year, 78, at 2 years, almost 100, and here at the 5-year, it is 100. The subscales, symptoms, pain, ADL, activity of daily life, sports, and quality of life. Here you see the pre-operative, the 3 months, 6 months, 1 year, 2 year, 3 year, 4 year, and 5-year follow-up. In all scales went to 100%. Also the concerning sports, 6 months, 1 year, 2 years, 5 years, no restriction in playing sports. The foot function index at 5 years. And here the patients at 3 years already. And if you want to read further on this patient, it is published in the Case and Ankle series of Foot and Ankle Surgery in July this year. I thank you for your attention, and I believe we open the floor for discussion.
Thank you so much, Niek. Now, after this brilliant case and impressive case from Niek van Dijk, we'll also have a presentation from Professor Martin Lind concerning knee application of the Episila. Martin, the floor is yours.
Yeah, thank you, Hélder. And Joseph, if you could start my case presentations, then I'll go through a couple of typical knee cases that had good outcome with the Episila implants. The first case is a 53-year-old woman with 2 years history of pain symptoms from left knee, no trauma. Typically, it's activity-induced pain and swelling of the knee. And this is her MRI scanning. She had significant cartilage pathology to the medial femoral condyle, clearly degenerative type lesion, grade 3B, with almost exposed bone centrally. And there was also some minor trochlear and lateral lesions. So it is a degenerative pathology. So this is how the case looked in surgery. So we can see the cartilage lesion arthroscopically, which is quite deep centrally, but also surrounding further pathology. And after reaming, we can see the guides, the implant guides showing its position and after implantation, and the X-rays with a well-implanted twin implant, since the size of a lesion needed a twin implant and not a circular one. And this is her 1 year outcome. She's now pain-free and is highly satisfied. And her Q scores at 1 year showed 20 to 25 points improvement in most of the scores, especially her activity and quality of life score improved more than 20 points, and clearly clinically relevant improvement. And she came back 3 years later with similar symptoms of her contralateral knee and requesting the same treatment. And at that 3 year outcome, her first knee was still the same with very good symptom relief, so even at this longer outcome time point. The second case is a 50-year-old male, 2 year symptoms from left knee. He had a long history of knee surgery. 20 years prior, he had a microfracture. 16 year prior, an osteochondral implant or both procedure. And then he actually had good outcome for 10 to 12 years. But now he gets increasing pain with activity. His MRI scanning demonstrated that his pathology was on the previously treated medial femoral condyle. There was varying chondral fissuring around and the subchondral bone changes from an OATH procedure with beginning cyst formation, but there was actually no major degenerative pathology. But there was also some trochlear wear. The MRI reports demonstrated this significant both chondral and subchondral pathology at the previous implantation site, but also trochlear wear. And also, he needed a twin implant to cover the cartilage pathology area, as demonstrated by the report. And this is his surgery. On the arthroscopic picture, you can see remnants of the osteochondral implant or transplant that is still in place, but surrounding further and further surrounding cartilage pathology. And then the reaming size and the implant in place, also radiographically. And his outcome is seen here. He had reduced pain and was able to return to low impact sport, and he was highly satisfied. And also he had around 20 points improvement in Kuh's subscales at 1 year. Thank you. And that was the two knee cases, and that would lead us to an overall discussion. We can start now.
I have a question for all faculty. In the first generation of this implants, we had a report that Martin and team shared of around 25 to 45% failure in the knee, and in the similar age, in similar stage, Niek reported 2.5% failure in the ankle. Do you think that's got to do with biomechanics and the fact that each position, it's a different challenge that needs to be studied by itself.
So we have these early high revision rates known from registries in the knee. And I think what happened in the beginning of these resurfacing implants, for at least for the knee, was that people got maybe a little too eager in treating clearly osteoarthritic lesions with this sort of minimal invasive procedure compared to a total joint. And I think many of these implants were then inserted in not focal implants, but early osteoarthritis that was more generalized. And then these patients, of course, had a more sort of advanced pathology, which then led to an early failure. So that I think if you select these patients more clearly, that you're not having a fully osteoarthritic pathology, the outcome is a lot better.
And I agree. I have seen, and also I now see indications for an Episila, which are not an indication in the sense that, like you're saying, it are non-focal defects. I mean, if there is on the MRI, you have on the opposing surface bone marrow edema, then it's a non-focal defect. And then a metal implant is not indicated. So the indication is important, but also the technique. And in the ankle, the technique was really, for the hemicap, was really not easy. Like I was explaining with this K-wire, it had to be perpendicular in all directions. And if it was 1 or 2 degrees off, then it's already a tilt and it doesn't fit any longer. So I believe it was an implant that really had the failures in it by having a relatively difficult technique of implantation, and it's much more easy with, of course, with this tailor-made, patient-specific instrumentation.
This is why I strongly believe that metal will not be the final solution in orthopedics in future, but the current development of this 3D and patient-specific techniques, it's absolutely mandatory for our continuous learning and developing, because matching and the anatomy will answer at least some of our very important difficulties. I don't know if we have any other question from the participants.
So there was one participant that asked about the feasibility of using multiple implants for the knee, because in the knee you have a large articular surface, both in condylar area and trochlear area, whether it would be beneficial to do multiple implants. And Tim, you had some experience with this, and we also had a little bit of data in our big European study. So what is your take on the multiple implants?
Yeah, those are not included in that study, which we're focusing on the single implants, just to really keep it a focused, close group. But there were 6 or 7 in who have been done with the double implants. So I think for the right indications, again, isolated lesions, it's going to be a really good option to do. 3 implants, I think that's pushing it. But if we've got nice lesions and a good tibial surface, then this is quite an exciting next option. And
another surprise in our data from the European study was that the trochlear implants are doing quite well. And starting off with the Episila and also some of the other implants, I didn't find very good implants or outcomes early on with some of the other implants in the trochlear. But the outcomes with the Episila has been quite surprisingly good. And that's solving a problem that we have had for a long time. The trochlear was hard to manage, but we had really good outcomes with trochlear lesions.
Yeah, personally, I did the femoral condyle first. And then once I'd heard that the trochlear, others were doing the trochlear, then I've been doing that as well. And I agree, it's impressive, because those seem to cause quite a lot of pain, some of those trochlear lesions, and if we've now got that implant, it does fill a gap. And your second case was after Oates procedure, where there's quite a deep area of abnormal bone, and that also that's impressive to see how it's really allowed filling in of that area as well. So it does, that tailor-made aspect to it is quite good.
We have a question from the participants asking if post-operatively can the patient be immediately full weight bearing. I believe this is for the ankle, but I'm not sure.
Well, for the ankle, we have the osteotomy. You have the osteotomy on the medial lateral side, and the osteotomy demands 6 weeks of immobilization and a partial weight bearing. So it is not the Episila, which because that could be loaded, but it's the osteotomy which directs the rehabilitation and the immobilization period.
Comments from the knee?
For the knee, we still go for partial weight bearing for the first 6 weeks, but free range of motion, no brace or anything, because the early bony healing to the hydroxyapatite is critical, not to have any micromotions, and this partial weight bearing is probably still the safest, but not anything complete at offloading.
We have a comment that I think it's more a comment, but it's something shared that trochlear lesions can benefit from a metallic implant, but this participant states that probably all biological options should be tried first. This is what I understood. What do you say about it?
Well, the trouble is biological options, just when you're 45, 50, they just don't seem to do so well. That's our challenge, is to have something at that age group where the metal implant is more indicated. Sure, 20, 30-year-old, we should be absolutely doing the biological options, but 45, 50, 55, I think they have a lower success rate.
Yeah.
That's my view.
Yeah, and my personal opinion is that I go up to 40 with biology, but never above. And that's where these metallic implants come in place, filling the gap. So I don't think there's really a room for trying biology above 40, because the outcomes are so poor. It will be wasting the patient's time. And also from our study, we see that we do have worse results in patients that had previous biology treatments performed. So actually we are burning not all bridges, but some bridges are burned with previous microfracture especially.
Well, that's an interesting observation, because for the ankle, I would have said before your remarks that we start with biological approach, and then if the biological approach fails, then we go for a metal implant. Except for the large lesions, because the primary large lesions, we know that they have a high chance of failure. So there, the primary metal implant or a primary OATS comes into view. But I might have to revise after what you just learned me.
And this is the last question that we'll take. The cutoff edge for age in the knee, is it 40 for everybody? And Niek, do you have any comment on age limitation or indication once you presented a case of a 33-year-old patient returning to soccer, recreative soccer?
No, I don't have an age limitation. Of course, you don't do it in adolescents, and I should say you don't do it in the younger patient. But sometimes you have a patient and he had already 2 or 3 biological surgeries. He had an OATS, and now he is 26-year-old, and now he's up to an arthrodesis because he's too young for a prosthesis. And then I will still do the Episila. So you have to judge it case by case.
Knee faculty? Do you have age limits?
I wouldn't go below 35 with the resurfacing implants. So we still don't know enough about the longevity of these implants, and the need for revision if you start too young could be high.
Yeah, I think that's as well. I think that's true. We should have biological solutions in that age group. But if it's a revision, we know that ACI, cell-based, does not do so well after previous microfractures, so options do start to run out. But the patient's more likely to be active on it and understanding the long term. So, yeah, 40, 45. It's not like a rigid one line. 40, 45, that sort of age group.
Okay, I think we could stay here much longer, and I think it was really funny, and it was great to see you all. I believe we can say that focal cartilage and osteochondral lesions of the knee and ankle are an important source of patient's impairment. And there is this treatment gap for patients with this significant symptomatic localized cartilage and OCD lesions in the absence of fully developed osteoarthritis. Mini resurfacing implants for the treatment of symptomatic cartilage and OCD seem a feasible and clinical beneficial treatment concept. This Episila implant represents second generation of mini resurfacing implant that is anatomically patient-specific and has advanced some healing features with improvable engineering. And in 2021, there is no evidence of any superior treatment for primary or secondary ankle OCD. And for sure, patient-specific metallic endoprosthetic resurfacing implants have a role in the approach of such injuries. This might represent a first step in development of future tissue engineering biological replacement of focal OCD defects, and keep on with the pillars of knowledge. Pain comes from the bone, so we need to treat the bone. Remember the concept of edge loading, and check alignment. Orthopedics, it's all about alignment. Thank you so much to our educational partner Episurf Medical for the support to this webinar, which will be shortly available on the ESSKA Academy. Please fill in the survey after this webinar. Your feedback is very important to us. Ask a member and Academy users to claim your certificate. Complete the survey shown in your chat box or internet browser. And the certificates will be available in your ESSKA profile from Friday, 24th September onwards. Be part of the scientific program of our upcoming ESSKA Congress, and the deadline for abstract submission has been postponed, so we still have a chance. And visit our website. Thank you for your attention. We hope you enjoyed this session as much as me and all the faculty have enjoyed, and I hope to see you all very soon in the near future. Thank you.